Hey everyone, I'm Harshal, and welcome back to this Masterclass Explainer. Today we're diving deep into the exact rules, those tricky time thresholds, and the compliance guardrails for behavioral health integration and the collaborative care model. You know, if you're handling billing or admin in primary care, you already get it. Integrating behavioral health isn't just some clinical pipe dream anymore. It is a financial and operational must-have. But let's be real, the coding rules around it can be incredibly strict, so let's break it down.
Here's our roadmap for today. We'll start with general BHI, look at the COSIEM framework, and then dig into COSIEM time tiers, the required infrastructure and registries, co-billing rules, and finally, top audit red flags.
All right, let's jump right into Section 1, General Behavioral Health Integration, focusing on the scope and thresholds for CPT 99484. So the big takeaway here is that code 99484 acts as your standard gateway for managing behavioral conditions right within primary care, specifically using your clinical staff. It covers care management for patients with mental, behavioral, or psychiatric conditions. And yes, that absolutely includes substance use disorders. Now, there is one huge clinical caveat before you start billing. If the patient hasn't been seen by the billing practitioner for an E&M visit within the last 12 months, you have to do an initiating face-to-face visit before you can start billing for these BHI services. Keep that in mind.
Now, to actually build this code, you've got to hit a very strict minimum threshold, 20 minutes of clinical staff time per calendar month. Not 15, not 19, 20 full minutes, all directed by a physician or a qualified healthcare professional. This is a hard floor, guys.
And during those 20 minutes, your team can't just be having a casual chat, right? They need to deliver specific, documentable clinical elements. We're talking about conducting systematic assessments, administering validated rating scales like the PHQ-9 for depression or the GAD-7 for anxiety, actively revising the care plan, and coordinating that ongoing treatment. Moving right along to Section 2, the Collaborative Care Model or COSIEM framework and its evidence-based team approach. Think of COCAM as an upgraded, highly structured version of BHI. It's designed for patients who need much more intensive, coordinated oversight. It basically takes the whole concept of behavioral health integration and layers on a highly specific, evidence-based team framework. To bill for COSAM, you absolutely must have this tripartite team in place. You can't just piece this together with 2 out of the 3. You need the primary treating practitioner, who's the one actually billing the service, a designated behavioral health care manager to do the heavy lifting of patient tracking, and a specialized psychiatric consultant.
What's really fascinating about how the CPT guidelines define that third role is that the psychiatric consultant typically doesn't even see the patient directly. Instead, they act in a consultative, behind-the-scenes role. They advise the care manager and treating practitioner on differential diagnoses, prescribe treatment strategies, and offer medication management advice. It totally empowers the primary care team to handle complex psychiatric needs.
Okay, let's get into Section 3, COSIEM codes and time tiers, where we'll decode 99492, 99493, and the add-on 99494.
Listen up, coders and billers, because this is exactly where the time-based math gets rigorous and honestly where most of the revenue leaks happen. For the very first month of collaborative care, you're looking at CPT 99492, which expects 70 minutes of care manager activities. Then, for the second month and all subsequent months, that baseline drops. You'll use 99493, which represents 60 minutes of time. And hey, if your care manager is spending a ton of time with a really complex patient, you can use the add-on code 99494 for each additional 30-minute block. Oh, and I want to throw in a critical piece of info here for your Medicare patients, HCPCS code G2214. Think of G2214 as your lower threshold COSIEM option. If your care manager only hits 30 minutes in a month, meaning they fall short of the 70 or 60-minute rules for the primary codes, you can build G2214 to make sure that 30 minutes of hard work doesn't go uncompensated.
If we look closely at the CPT duration brackets, you'll see a bit of a relief. You don't actually need to hit exactly 70 minutes to bill 99492. The magic threshold is crossing the midpoint. So, hitting 36 minutes is the absolute minimum required to even report that initial month code. If you only hit 35 minutes, nope, you can't report 99492. Precision in your time tracking is literally everything here.
Next up is Section 4, Operational Infrastructure and Registries, focusing on the mandatory clinical systems.
Here's the deal. You can't just track time and call it a day. You need specific operational infrastructure to actually legitimize these claims. You cannot wing it with COCAM.
Maintaining an active electronic patient registry is a fundamental, non-negotiable requirement so you can track outcomes systematically. On top of that, your care manager and psychiatric consultant have to conduct weekly documented caseload reviews. If you're just doing casual, unstructured catch-ups once a month, you are definitely not meeting the operational requirements for collaborative care.
All right, Section 5, Co-billing Rules and Exclusivity. Let's navigate concurrent care management.
So what exactly happens when your behavioral health patient is also receiving chronic care management or remote patient monitoring? Let's clarify this overlap. First up, mutual exclusivity. General BHI and co-CM cannot be reported together for the same patient in the same calendar month. They're two different pathways, so you have to pick one. But the co-billing allowances are a bit more generous. You absolutely can bill co-CM concurrently with chronic care management or remote patient monitoring. The catch? The clinical staff time and the services provided must be strictly separate and distinct.
And this quote right from the CPT guidelines is your absolute golden rule. No double dipping on your minutes across different care management programs. If your nurse spends 15 minutes checking on a patient's diabetes for CCM and then 20 minutes running a PHQ-9 and discussing depression management for COCM, you must have two distinct, cleanly separated time logs in your documentation.
Finally, we arrive at Section 6, Top Audit Red Flags. Let's talk about protecting your practice from those dreaded denials.
Let's wake up and talk compliance, because this is where people make incredibly expensive mistakes. If an auditor comes knocking and sees co-CM billed without a formal documented psychiatric consultant relationship, or they notice you're operating without an electronic patient registry to track outcomes, you are looking at immediate clawbacks. Missing your weekly caseload review notes, or having overlapping time logs where you double-counted minutes for CCM and co-CM, those are guaranteed ways to fail an audit.
To keep your practice perfectly safe through all of this, you must always clearly define the total time spent and the exact date of service. Explicitly list the activities performed during that time, like write down care plan revision or registry update. Make sure to identify the exact provider or clinical staff member performing those activities, and maintain a crystal clear audit trail that totally separates your time-based services.
By applying this masterclass framework, you're going to secure the behavioral health revenue your practice truly deserves, all while keeping your operations entirely audit-proof. But I want you to ask yourself, how many unbilled minutes of care coordination is your clinical team already doing that you're just leaving on the table right now? Protect your time and protect your practice. Don't forget to like, share, and subscribe to Decode Healthcare with Harshil.